Today we're going to talk about pacing lead in the left pericardiophrenic vein. And this is one of the steps in the Respicardia Implant procedure. And so to orient you here, we have the right brachiocephalic vein, which enters the SVC, and then the left brachiocephalic vein, which actually takes off at an angle below or inferior to the right brachiocephalic vein. And then out here we have the pericardiophrenic vein, which circles around the outside of the lateral wall of the left ventricle, and then under the diaphragm in anastomosis with the inferior phrenic vein, which then dumps into the inferior vena cava. And sometimes this connection is obvious and sometimes it's not. And then of course the coronary sinus. So the way we would start the procedure, have our initial access. Then what we do is we would take a renal LVI, so that looks like this ordinarily, and it's a 5.5 French, and then through it we would put the vein selector, and in this case we're going to choose the vertebral vein selector. And then what we'll do is we'll advance the vein selector and then head it towards the brachiocephalic. And you can usually do this with puffs of contrast. Now of course we have our injection system connected like this so that we can, with a Y adapter, so that we can puff contrast and see where we're going, and we also have torque control. So we would then aim it into the brachiocephalic on the left, and then once you have it in the proper general direction, then you could slide it along, or you could use a glide wire. And what's really nice is you can open up this hemostatic valve and slide the glide wire right down into the vein selector, and then out into the brachiocephalic. And then you would be able to advance the vein selector and the renal. Notice that the LVI, the blue, is going along there as well. And then once we get past where the brachiocephalic is likely to be, we'll take out our 035 glide wire so that we can use contrast through the vein selector to localize the pericardiophrenic vein. And so we have our reservoir syringe here, and then we'll just fill up, and this would be our contrast, and then we would just drive the vein selector back, and using little puffs of contrast seek to engage the takeoff of the pericardiophrenic vein. And there's a couple of different shapes of vein selectors, of course. There's the hook and the renal, and in this case the hook and the standard, and in this case the vertebral shape engaged the pericardiophrenic vein quite nicely. So now we want to put down a wire. I'm going to put down an angioplasty wire, and my favorite is the Choice PT floppy because it goes easily, and you're going to rely on the subselector for support. So we would then advance the wire down into the vein, and let's say the vein was difficult to advance and we were having trouble advancing. What we could do then is add a Microcross catheter. which is basically just an 014 catheter that facilitates movement of the wire and actually fits inside of the vein selector, which is really nice. So we flushed our microcatheter, and now we're going to advance the microcatheter over the wire. And this will do two things. One is it'll provide additional support to the wire. And number two, it'll allow you to exchange wires in the event that the wire becomes bent or twisted and you can't advance it. So here what we'll do is we're going to advance the microcatheter back just a little bit on the vein selector. Advance the microcatheter. And now right here you can see the tip of the microcatheter coming out. And that's basically strengthening the wire. Now you can also then change the wire. Let's say that this wire was all bent and wouldn't go anywhere. But you could see that there was an anastomosis to the inferior pericardiophrenic vein, but you just couldn't get there, and your wire was all bent. You could exchange for a fresh wire. But in this case, what we've done is we've reinforced this wire, which started off as a floppy, and we could now make it an extra support with no trouble. We just take this wire out, put a fresh wire in. But oftentimes, that combination of the microcatheter and the vein selector gives you enough additional support that you can then advance the vein selector. Now we're advancing, you can see we're advancing the vein selector now, and we're advancing the vein selector and the microcatheter and the subselector nice and deep into the target vein. So we'll just keep sliding it on down, and now we have our subselector, which is 5.5 French in internal diameter, all the way down into the pericardiophrenic vein. And so you know for sure that the lead is going to go as far as that. So then what we would do is we would remove the microcatheter and the vein selector, keeping the wire in place. We have our subselector, or the renal, which is now all the way deep into the target vein, which is in this case the left pericardiophrenic vein, with a wire. And so advancing a lead with that sort of stability over a wire is very easy. So we would just take our pacing lead and advance it through the subselector and down into the pericardiophrenic vein. So getting a lead into the pericardiophrenic vein with this approach can be very easy. And there's pericardiophrenic vein, and then we would withdraw this. Now if it turns out that the renal LVI is too long, once you get it all set up, you could just cut this off and then put the lead in and then slice it away. Or you could put a 6 French sheath on it, but that's another discussion. But this just shows you how easily this whole thing can be done. And then we would then slice away the subselector. all the way down, finger over. It's the same technique you use for LV leads. Thumb underneath and slice. So that would be the interventional approach to LV lead placement, or excuse me, to lead placement in the left pericardiophrenic vein, which is actually extremely simple, similar to that which we would use if we were doing an LV lead. Thank you.